All right, very good. All the board members are here. It's 6 o'clock, so let's go ahead and call this meeting to order if you're able. Please join me and stand in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. Roll call, please.
Director Yee.
Present.
Director Stewart.
Present.
Director Wallace.
Looks like he's frozen.
He's still in the Pledge of Allegiance.
Real technology. You can sit down.
He's frozen.
Okay.
Yeah, he's frozen.
We know he's here. Director Epen.
Present.
Director Nicholson.
Present.
Very good, thank you. Who else is in the room with you, Dee?
In the room, I have Kimberly Hart, Chris
Yay.
Henry, Larry Lavoisier, Tina Nunez, Paul Kozachenko, Shri Bodu, and me, D'Antonio.
Very good. Thank you very much. Well, welcome to the May 11, 2022 regular meeting of the Washington Township Healthcare District Board of Directors to continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by the SARS-CoV-2 virus. The Brown Act allows a local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue to meet remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Health Care Services Public Health Department COVID-19 website at www.covid-19.acgov.org. I ask for a motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Madam President, I make the motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Thank you, Dr. Nicholson. Is there a second?
Second.
Thank you, Dr. Epen. Roll call, please.
Director Yee.
Aye.
Director Stewart.
Uh-oh.
Aye.
Oh, there you go.
Director Wallace.
Aye.
Director Epen.
Aye.
Director Nicholson.
Aye.
Very good. Thank you. That passes. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Moving on to communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? None. Is there any written communication, Dee?
There is not.
Very good, thank you. We'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? Okay, hearing none, may I have a motion to approve the consent calendar items A through D?
Yes, Madam President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the consent calendar items A through D.
Very good, thank you. Is there a second?
Second.
Thank you, Dr. Epen. Okay, roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Eben,
Aye.
Director Nicholson.
Aye.
Very good, thank you. That passes. Okay, we'll move on to presentations. I'll turn this over to Kimberly, please.
Thank you, Madam President. I want to begin by just acknowledging that we have two very special weeks that are happening in May, and that's National Nurses Week and National Hospital Week. So I'm just going to take a few minutes and talk about each, and I know we have a video at the end and then also some photos. But I think we all know these are opportunities to express our gratitude for the dedicated caregivers who stood up during the healthcare storm of the century and gave so much, both professionally and personally, to care for our patients and our community. So last week, we celebrated Nurses Week, and it was the opportunity for all of us to recognize and show our appreciation to our team of nurses who on a daily basis, 24/7, dedicate their talents to serving our patients in our community. No matter where our nurses work, whether they're in the inpatient units, the procedure areas, outpatient settings, administrative functions such as quality, infection control, CDI, case management, education, or management, they are all part of a team that helps to ensure our patients receive the care they need. A long-standing tradition at Washington Hospital during Nurses Week includes the high tea celebrations. In order to include all shifts, the tea first begins at 4 a.m. and includes savory and sweet treats in a beautiful setting. Our food and nutritional services outdid themselves to show their appreciation to our nurses. On Tuesday morning, the Fremont Police and Fire came out in force to honor our nurses at shift change, greeting both those coming into work and those heading home. Members from both Fremont Police and Fire lined up along the entrance and held handmade thank you signs and offered refreshments. The week continued with surprises throughout the day, and a professional development theme with an educational fair and headshots taken by a professional photographer were part of the festivities. While we may reserve only 1 week a year for special nurses events, we appreciate their commitment to our patients, their families, and our healthcare system each and every day. The second week in May is Hospital Week, and this year's National Hospital Week theme is We Are Healthcare. And we're celebrating it right this week. So during this week, we celebrate all of our staff, our physicians, and our volunteers, everybody who contributes to patient care and our patient-first ethic, no matter where you work, whether it's clinical or non-clinical. Because all these individuals come together to create a team that serves our patients and makes our healthcare system strong. We began Hospital Week with a fun giveaway of past promotional items, and today everyone enjoyed a meal catered by Strizzi's with drawings for more giveaways throughout the day and evening. On Friday, we'll announce special winners of special prizes that include eye watches, robotic vacuum cleaners, and massage therapy guns. Throughout the week, leadership within the organization are sending a message each day to the employees, physicians, and volunteers within the organization, recognizing them for their commitment and thanking them for their hard work each and every day. The initial email on Monday was sent from me with a link to a special video that we will see shortly. So this video that we're going to show was created from messages from several employees and volunteers, and I appreciate their time and creativity. So Shri, if you want to play that.
I work in healthcare because it's a very fulfilling job when you know you can make a difference in people's lives.
I enjoy working here because it allows me to provide compassion, patience, and empathy to our patients.
I like working as a nurse because it helps me be a part of people's well-being.
I'm able to passionately care for the members of our community. Happy Hospital Week from 6 West.
We love working here and we love taking care of our patients.
My name is Yolanda. I'm a registered nurse in pediatrics. Happy Hospital Week. I'm in healthcare because I want to make a difference. I want to make someone's worst day the best day that they could have and spread some sunshine while I'm at it.
I like learning from the other disciplines.
I get to work with an amazing team in the operating room.
Teamwork is equal collaboration from
communication, trust, reliability, and coming together.
It enables us to complete the task at hand much easier.
Teamwork is to us in our department is serving our patients with comfort, care, and making sure that they're satisfied and well taken care of.
What teamwork means to me is helping and supporting each other at all times.
Teamwork means being there for each other and have each other's back.
Loving each other.
Awesome. Working together.
I work around people who really care for not just the patients, but each other, and it just is a joy to be here.
Right there, right now.
Teamwork makes the dream work.
Team on 3, 1, 2, 3.
Happy Hospital Week.
Happy Hospital Week from Labor and Delivery.
Happy Hospital Week.
Happy Hospital Week.
Thank you so much. It's so fun to see and to hear all that great feedback from the staff. What a great opportunity to celebrate them this week. Great. Anything else for me, Kimberly? Is that it?
Would you like me to move forward with introducing John Lee?
Oh yeah, yeah. Go ahead. I was happy to do
that.
No,
I did want to just say I think that the biggest piece and the two simplest words that mean the most is really thank you. And I do want to thank all of our physicians and our staff and our volunteers for all that they do for our patients in our community. So that is what I have to say. Thank you.
Thank you very much. All right, let's move ahead and give us our time and attention to John Lee. He comes from Information Services with some information about MyChart.
All right, why don't I will introduce John Lee. I think most of you know he's our Chief Information Officer, and he received his undergraduate degree from the University of California, Berkeley in 1996. He also received a certificate in computer networks from Coleman College in 1997. He's a graduate of Leadership Fremont and is Lean certified. His 25-year professional career includes information technology management positions at National Pen Corporation in Rancho Bernardo, Celerity Inc. in Milpitas, and Purple Communications in Rockland, California. During his 9 years at Celerity Inc., a semiconductor equipment manufacturing company, John was part of the executive leadership team and directly responsible for worldwide IT operations. John joined Washington Hospital in 2010 and his primary responsibility to implement a high availability electronic record system. John led the technical solution team which successfully implemented the Washington Epic electronic health record ReCare from 2011 through 2013. In 2015, John was named Chief Information Officer. And in this position, John oversees information services, operations including communications, telecom, infrastructure, client services, security, project management, and all applications and systems, including our Epic electronic health record. John also serves as an active member of the board of directors for locally based nonprofit Abode Services, which works to end homelessness by putting housing first. So thank you, John. As mentioned, you're going to talk about the patient portal.
Thank you, Kimberly, and thanks everybody for giving me an opportunity to share a little bit about MyChart, our patient portal. I'm going to share our screen here. And get it blown up. Okay, so I think many of you are aware of MyChart and what MyChart is. It's a solution portal from Epic Systems that now has over 150 million patients that utilize MyChart for their records and tracking those records. And it's something we've had here at Washington for a number of years since we went live back in 2013, but we continue to expand upon it. And I just want to talk a little bit about the value of MyChart and what the benefits that you have that you can utilize it here at the hospital. So what is MyChart? As Kimberly mentioned, it's really our system-wide patient portal system. Why would you want to use MyChart? You want to have access to it in order to improve your care coordination. There's a lot of information in MyChart. You can track your own personal patient information. There are communication options within MyChart for reaching out directly to physicians and clinic staff. And of course, the bread and butter is really viewing the history of your labs, the results, your radiology studies, and now you can also use it for direct scheduling of appointments and e-check-in. So how do you get signed up for MyChart? Well, you really need to receive a code, and you can do that in advance of a scheduled appointment, or you can do it while you're at the provider. And really, it's as easy as getting a SMS or a text message or an email address, so you can get into your MyChart and build that account. From our website at mychart.whhs.com, you can either request a code that way, or you can also use a third-party integration we have set up with Experian, so you can validate and verify who you are so that we make sure that that record gets set up for you. And so that's as easy as going through those steps. You don't even have to wait for our staff to validate you through other means. MyChart can be used via the web, as I mentioned, or as an app on your phone, for instance. And it is, has security built into it to make sure that your record maintains its security from others. So the meat and potatoes of what's inside MyChart. Whether you have a WTMF provider, through the Washington Township Medical Foundation or not, there's value in utilizing MyChart. You can use it for document review. As I mentioned previously, it's very easy within the My Records section to look at your lab results, look at your x-ray reports, and then as part of the the COVID rollout, we now have a section where you can acquire your digital QR code for your COVID test results and vaccine status. So it's easy to pull up if you ever need to prove out that you have had the vaccinations and or that you tested negative recently for COVID. That is also available so that it can be pulled up and then scanned at an establishment in order to validate your status. Your after visit summary. If you visited the emergency department, you visited one of our clinics, the after visit summary, which has all the instructions for what to do after your visit, which is a very important part of your healthcare, to go through that process and know what the doctor has asked you to perform or what the next steps are for your healthcare. You can see that within MyChart. And it's just so much easier than having a binder, for instance, or having that paperwork. You have a digital notebook, in essence, through the MyChart application. You can see your clinical progress notes within MyChart. Messaging is another great feature within MyChart. If you wanted to contact your WTMF provider, or we have several WeConnect providers. Now, WeConnect is a program we've rolled out which allows physicians in our community who are not part of Washington Township Medical Foundation, but are utilizing our Epic system to connect through that. You can provide questions to them about your health. You can use it for sharing your record outside the system. So even if you are not always utilizing a Washington physician, for instance, you can share your information out to, for instance, someone else in another healthcare system. Or for instance, if you went to see a specialist, you can share those records out as well via MyChart. So it really does make sense to still have that information at your fingertips through the application, so you can share that out whenever you need to, or provide proxy access to another individual who is providing care for you directly, for instance, in your home. You can inquire about recent test results, refills, and also request a referral. all within MyChart. Okay, so some of our more recent developments are appointments through direct scheduling. So if you do have a Washington Township Medical Foundation physician, you can directly schedule within MyChart for Warm Springs, Nakamura, our Danielson Clinic up in Newark, Women's Health, Peds. You see the list there. And basically, you just go through a process of saying, why am I coming into the facility? What do I need? And then you can get your schedule completed right there for your upcoming visit. If you don't have MyChart, we do also allow open scheduling through the mywtmf.com website for primary care and peds visits. And so then maybe after you get in for the first time, for instance, you can then sign up for MyChart and use it going forward as well. Appointment reminders and e-check-in are also possible via MyChart, so you can sign up for reminders for upcoming appointments. You can get those through email, for instance. You can do e-check-in. So if you wanted to make sure, hey, I want to check in, I'm on my way, I'm going to go ahead and say I'm going to save time, get everything filled out, any questionnaires completed through the app, you can do that so that when you come in, you can just be ready to start your visit right there and not have to start with filling out paperwork when you arrive. There's a couple of graphs here I wanted to share as well. Visualizing your health care over time. This is one of my favorite things within MyChart. You have records that can go back years, seeing exactly where your cholesterol level was, your glucose level, your weight, different things, and it's graphically available to see, so you can really see how your health is trending. As we all know, your care is so important in terms of your historical baselines and where you're at today versus where you were at previously. These are things that can be pulled up and viewed within MyChart. Okay, just a few words about future enhancements. We are looking at incorporating bill pay into MyChart, so you'll be able to do that. We're also adding additional questionnaires all the time, some around quality of life, reviewing of symptoms, and physical forms are in the works right now. We're working on adding additional Washington Township Medical Foundation clinics for direct scheduling access. Some of the specialties that aren't on there right now will be added in the future. And other things like pre-procedure instructions and allowing people to reschedule through a direct link. So there are always changes coming to MyChart to make it more useful and more advantageous. So in conclusion, I say, why not use MyChart, right? It really does have a little bit of everything. It is our patient portal for the Washington Hospital Healthcare System, whether that's through our clinics, through our inpatient areas, through our outpatient providers. It's the one digital location for all of your information. Again, you can communicate directly with physicians and clinic staff, but most importantly, you can stay on top of your healthcare needs with easy access to your records. And if you want to share those records or you want to, revisit them at a later time, that's always available to you. And of course, like I mentioned, there's direct scheduling and e-check-in services as well through the app or through the website, however you want to get to MyChart. Anyway, I hope you've enjoyed a few minutes on MyChart, and at this point I'll stop sharing and I'll see if anybody has any questions.
Safety. How safe is it to use?
It's very safe to use. Obviously, you think of digital records and healthcare that's accessible through the internet, et cetera. But, really, we make sure that the people that get access are only the right person who has to access the record. And then, we have lots of technology built into the website to ensure that it's a secure connection. There's no data stored on your end device. It's going to stay out there for anybody to view, even if you're on a third-party computer or something like that. So it is very safe to use.
Thank you. Any other questions for John? Well, thank you very much for sharing all that.
Appreciate your time. Thank you.
I'm a user.
Good. There we go.
Very good. Thank you. All right. Well, let's move on with our report. heading us off, I think that will be you, Kimberly, on the first report on trauma center designation.
Yes, thank you. This evening, we want to give the Board of Directors and the community an update on trauma center designation. I think all of you are aware that for probably over a decade now, we have been discussing the need to be able to be a trauma center for Southern Alameda County. We have seen, unfortunately, patients having to cross county lines to receive the necessary trauma services, or having to travel north to Eden. And as we all know, during traffic times, that can take almost an hour. And as we know with trauma, that minutes are very important, and in order to get care as quickly as possible. So last year, Alameda County agreed to bring in a third party to do an assessment of our county's trauma center, or system, I should say, and it really hasn't changed since it began in 1987. Both Washington and Stanford Valley Care expressed the desire to become a designated trauma center. And just 2 weeks ago, Bishop and Associates has come forward with the report, and they presented that to the Board of Supervisors. And so this evening, Tina Nunez, our Vice President of Ambulatory Care Services and Administrative Services, is going to give that update that was presented to the Board of Supervisors and talk about some of the next steps. I do want to say that the final decision has not yet been made, because it does need to be made by EMSA, and that there is some good news, but Tina will talk about exactly where things stand. So thank you, Tina.
Great, thank you, Kimberly. So some of this Kimberly just mentioned, but I'll just go over it. Just a reminder of where things stand. So the county commissioned a consulting group, Bishop and Associates, to study the current state of the county trauma network. Findings from the study were announced at an April 26th special meeting of the Alameda County Board of Supervisors, which was held with the Board of Supervisors and the Emergency Medical Services Authority, also known as EMSA. The conclusion of the study was that the county will indeed need another level 2 trauma center in the next 5 years. And the recommendation was that Washington Hospital is the best choice to be designated that trauma center. The study proposes establishing a trauma service area for Washington Hospital covering Hayward, south of Industrial Boulevard, Union City, Fremont, Newark, Sonoma, and the southern portion of the Tri-Valley area. So you'll see that on the map on the right-hand side, that purple, light blue purple area. And currently, that area has a population of 415,000 residents. As you'll recall, and as Kimberly mentioned, Stanford Valley Care also applied to the county for trauma designation. And the study concluded that adding 2 trauma centers would destabilize the current Alameda County trauma network and was not a good idea. And so Bishop and Associates thought the county could reconsider Valley Care's bid in the next 10 to 20 years. So what this slide is representing is showing the trauma cases in South County that are leaving the county for trauma care. So there are 272 trauma cases that originate in Alameda County, in the South County, that are being taken out of the county for care. Each of these blue dots indicates where a trauma incident has occurred for patients leaving the county. And so basically every trauma patient south of Thornton Boulevard in Fremont is taken to San Jose for care because of the distance in terms of the trauma center. So what this slide is showing you, it's a little busy in terms of the table, but there's very important elements in each of these that I want to walk through. So as Kimberly said, just for background, Alameda County Trauma Network was established in 1987, and currently the trauma centers are in Oakland, there's Highland and UCSF Benioff Children's Hospital, and Castro Valley, there's Eden Medical Center. So those are the existing trauma centers that exist today in the county. So in terms of this table, the ED volume and staffed beds, essentially, which are those 2 first lines, are indicators of a facility's ability to flex up to respond to an influx of trauma patients. And these measures show that Washington Hospital has adequate capacity currently to accommodate more trauma volume. The trauma service area population figure speaks to whether there will be sufficient trauma patient volume to provide high quality care. We need enough patients to continue to have that quality care. And the population of South County is clearly greater and has more density, indicating that the volume of trauma cases will be high enough for us to maintain our quality standards. The consultant estimates that Washington Hospital would currently receive 722 trauma patients annually, rising to 859 by 2040, which is what the table is showing as well. Their recommendation for minimum volumes for level 2 trauma center is 750 per year, cases per year, which we will meet. The next data point here is showing the number of patients leaving Alameda County for trauma care in terms of South County and East County residents, and are currently being served by the trauma system. The consultants were careful to say that the current trauma system serves everyone adequately in Alameda County, but our perspective is that the absence of a trauma center in South County is less than optimal. Just like I showed on the previous slide, the fact that 272 South County residents are being driven south to San Jose suggests that there is a problem or a gap in service here. The last data point here is showing the combined projected trauma admissions plus the patients leaving Alameda County for trauma care, which for Washington Hospital is 995, which is above the 750 minimum volume. And as you can see, Valley Care does not reach that 750 threshold. So, and just to point out, South County residents have to cross, as I mentioned already, county lines to receive trauma care. And this played an important role in the recommendation for Washington Hospital to be that next trauma center. In terms of this next slide, and the staff has reported that the EMSA, Emergency Services Medical Authority, will be the one to make the final decision on the designation for the next trauma center. The briefing for the supervisors that was held in April was informational only, and essentially EMSA has said that they need to get the full report from Bishop and Associates and review this information in detail before making the final decision. As we've talked about already previously, Washington Hospital has had strong support from both cities, police, fire, and labor, with resolutions of support from the City of Fremont, City of Union City, City of Newark, City of Hayward. We also have letters of support from Fremont Police Department, Fremont Fire Department, Union City Police Department, and we've had testimony at the supervisor's special meeting. Mayor Lily May testified, Al Nagy, Mayor of Newark, testified. We had 2 community members testify, and we've had very strong support from our labor partners. We have letters of support from the Building and Construction Trades Council of Alameda County, also Teamsters Local 856, and at the testimony at the supervisors meeting, we had Doug Jones from SEIU, and we also had a CNA representative there testifying on our behalf. So very strong support, both from cities, fire, police, and as well as labor. In terms of potential roadblocks and opposition, we have heard in terms of, Eden Medical Center, there is a concern from Eden that we are hearing in terms of loss of trauma volume will threaten their quality of care in the future. And they are also questioning whether additional trauma center would have sufficient volume, which we've just shown that we will have sufficient volume. In terms of Stanford Valley Care, they intend to continue advocating for trauma status designation, and they are questioning the volume assumptions in the Bishop and Associates study. Now, the Bishop and Associates study has been concluded and recommends designating Washington Hospital as the next trauma center in the county, as I've already reported. But as we know, the decision has not been made yet by EMSA. And so we cannot take it for granted that the decision will go our way, and we need to continue to move forward in terms of our next steps. So in terms of next steps, the county EMS agency is currently developing its pre-designation process and is analyzing the full Bishop and Associates report. It's important that we stay part of the process and continue working with the county staff through this administrative process. There may be additional questions that EMS administrators have, and further clarification may be needed. But for next steps, we will continue down our path, and part of that is making sure that Supervisors Carson, Miley, and potentially the new member, visit Washington Hospital within the next few months. We also will meet with designated county decision makers to indicate our desire to move forward and to learn next steps. And we want it to include site visits with both Colleen Chawla, who is the Director for Healthcare Services Agency, and Lori McFadden, who's the EMSA Director. We do want to meet with Eden leadership to evaluate their concerns that we have heard. And we want to update our labor partners and individuals who spoke in favor to provide an update and thank them and continue to provide support going forward. And lastly, I think it's important, becoming a trauma center is a process that does take time and is a large undertaking, especially as it relates to ensuring that we have the appropriate physician coverage and other operational components in place. We know that it can take up to 3 years to put all the components in place. It's not going to happen overnight. A positive for us is that we have a lot of the infrastructure already in place, and this was cited in the report as well. We have a beautiful 39-bed ED unit with 2 trauma bays. We have the community support. We have a high-tech, newly built critical care facility. But operationally, we know that there is more to put in place for the infrastructure behind the trauma center, and we'll be working towards that. I'm happy to answer any questions in terms of where we are today and sort of where we're going with next steps.
Questions for Tina?
I don't have a question, but I would like to just really commend Kimberly, Tina, and the whole team as far as their robust efforts to provide Bishop with the necessary information, which led to their conclusions. And I really think that this just underscores our commitment to our community to be able to provide these services here. We hope that the decisions that are made are favorable to Washington Hospital, but more importantly to the community that we serve.
Mm-hmm. Thank you, Dr. Nicholson. Anybody else? Very good. Well, thank you very much, Tina, for that fine report. Next steps moving forward, not giving up. Appreciate that. Very good. Thank you. I believe Dr. Hyder's on. So we shall have his medical staff report next. Dr. Hyder?
Yes.
Welcome.
Thank you. Thank you so much. I'm sorry last time I was absent.
Welcome back.
Thank you so much. I appreciate it. So right now the Washington Hospital medical staff numbers are, they are about 346 active staff members and 36 allied health, and 92 are ambulatory and 8 are consulting and 25 are courtesy and 62 are professional, and leave of absence are 3 with a total of 572. And first of all, I would like to mention that Nurses Week as well as the Hospital Week, we have to really commend our nurses for their hard work and dedication in the difficult times which we had never in our life those last 2 to 2.5 years. And they really stood by and really shows their exemplary work for the care of the patient. And the medical staff and everybody is grateful for that. And we really appreciate that's the time, testing time, and they always stood by that. And the other thing with the hospital, we was also there, and we appreciate all the medical staff, appreciate all the administration, the board members, and Miss Kimberly Hart, who really gave such a dynamic leadership during the COVID time and continue to do that. And the other thing is, unfortunately, COVID cases are again increasing, and California COVID number has hit the highest point since February. Even though we have in our hospital, we have very low, but still it is we are coming across, so many people are telling COVID positive and all that. And recently Santa Clara has introduced back the mask and all that mandatory. And the other thing is individual PCR test for COVID-19 for pre-procedure or ER patient and inpatients. The production of the reagent needed for our laboratory in the individual PCR test for COVID has resumed. And so consequently, this test will be available starting tomorrow. In Epic, this test is listed as SARS-CoV-2 RNA by PCR. But if you can put as a mini, respiratory, it will able to, accept it, and they are going to do it. The other thing was clinical documentation query process will be sent to the Epic to providers from coding and CDR, promoting consistency and preventing duplicate queries being sent. Provider respond on the query form will be permanent part of the medical record, and still best practice to also have query response in progress notes and in discharge summary. Emphasize on concurrent CDI queries limiting post-discharge documentation, clarification, implementation of a standardized CDI query escalation process to provide for unanswered queries prior to the deficiency process initiating. And the medical staff will be, general medical staff meeting, it will be presented, and so that they are aware about this CDI queries and do it appropriately so that it avoids their, errors, and also it helps for the billing process. This is my report.
Okay, very good. Thank you, Dr. Hyder. Any questions for Dr. Hyder? Very good. Well, thank you and welcome back.
Thank you so much.
All right, next up, Debbie Fury. Let's hear what's going on with the Service League.
We're busy.
Yay.
Yay. April was another busy month for the volunteers. During the month, 94 volunteers contributed 1,344 hours on a wide variety of assignments, from serving in the gift shop to Morris Hyman. They're on the 4th floor in the main hospital and on the 3rd floor. And we are going back into the ED later this month. Yes. Yay. I'll be training. On April 9th, we also hosted an orientation for prospective new volunteers, and we got 6 adult, well, since January, we've gotten 6 new adult volunteers and 11 college. And in the orientation, we had 5 college volunteers and 1 adult. So we have a lot of college, and that they are very eager and they help a lot. So we're real happy. We also hosted our mid-year masquerade in the Anderson Auditorium from the 25th through the 27th. And the sale was popular as ever. And we really want to thank all the staff, because they were the ones that really helped the most of coming to the masquerade. A lot of the elderly were not allowed to come that were in assisted living facilities. They locked them in again. So it was really nice that the staff came, and we really thank you. That helps us be able to do the scholarships for the high schoolers so they can go to college. And we did over $6,000. So that helps a lot. And that's the end of my report. Is there any questions?
Thank you. Well, I'll put my volunteer hat on and say thank you to the hospital for the volunteer lunch for Volunteer Week. We appreciated being able to be together in the Anderson Auditorium and have lunch together and see faces again. And so I just really appreciated the hospital's support and in having that time for us to get together, and we did feel appreciated. So thank you.
Oh yes, that was so. It was so beautiful and so touching that that it was just really, really nice. And one of our things was like, we have real plates. It was just so nice. We were really touched. It was just beautiful, and they haven't stopped talking about it.
We don't take these things for granted anymore. So.
No, it's wonderful.
Yeah, great. Thank you, Debbie.
Thank you.
Okay, next. Oh, Mary Bohron next with our quality report. I always love to hear from Mary.
Thank you.
I welcome you. She's Chief of our Quality and Resource Management.
Thank you, Jeannie. Tonight, I'll be presenting on our first quarter of the year quality dashboard. So that will cover January, February, and March of this calendar year. And starting off with, going to the infection prevention indicators. Overall, we've had some great outcomes this quarter for infection prevention, some other patient safety metrics. And starting off with MRSA, which is a bug that's very difficult to treat with antibiotics. We did have 2 infections identified in the blood. After admission, we did identify some learning opportunities around the timing of doing the blood draws, et cetera, as it appears that these cases were actually more community acquired, but we got the blood culture a little later in the stay. So that's one of the areas we've identified here. They were not associated with devices. Moving on to catheter-associated urinary tract infections, we did have 2, which is about 1 more than expected for a hospital of our size and type. The good news is that we have not had any in the month of April or May since then. And so this actually is continuing to trend downward. And as we also move into the central line-associated bloodstream infections, otherwise known as CLABSI, we did have only 1, which is less than expected of a hospital for our size and type. So this is another great outcome. And I think with both of these device-related hospital-associated infections, we've really been working closely with infection control, quality, and nursing to make sure that we take a bundled approach to preventing infections developing in patients. And we've seen some good outcomes as a result of that. And we'll continue to do weekly education with the staff to make sure that we adhere to the bundle compliance. Our surgical site infections also have had great outcomes this quarter. We did not have any surgical site infections associated with colon surgery, which we know is a high risk for surgical site infection. This is a great outcome of the OR process from beginning to end. And the same applies with our next procedure, which is our hysterectomies. Abdominal hysterectomy, 0 this quarter, also great. You can see we've seen this consistently for now the 6th quarter in a row.
Wow, great.
C. diff, I'm very happy to report we continue to sustain much lower than expected numbers of cases of C. diff. We did have 2 this quarter, but again, it's far less than expected. The CDC would expect something closer to 9 or 10. And this is also a reflection of multiple teams working together, everything from the lab and how we test, nursing communicating with the medical staff about when is appropriate to test. And we've had a lot of really good collaboration there. So I think we're seeing that continue here. It's absolutely a sustained success now with C. diff. Hand hygiene is another area where we did see increased compliance this last quarter at 89%, almost there at reaching the Joint Commission goal for us, which is 90%. We've trained a lot more people to do hand hygiene observations, which means we have a lot more people on the units talking to the healthcare workers about hand hygiene and the importance of it. As we know, this is the single best means of preventing the spread of infection, and we're happy to report that we're continuing to see that increase. Our goal, of course, is to get this above the 89 and get it even above the 90%, which the patient safety team will continue to work on. Our nursing sensitive indicators also have had great outcomes this last quarter, starting off with our falls We are below the national benchmark for from national for falls for patients in a magnet hospital, which is great. This is really a reflection of making sure that patients are put in the appropriate place close to the nursing station when they're at fall risk, frequent rounds, making sure that patients use the restroom with assist prior to going to bed at night, have their call light near them, etc. All of those things, when bundled together, lead to great outcomes like this. And even the few falls that we did have in a large group of patient days were minor. And next, our hospital-acquired pressure ulcers, otherwise known as bed sores. The community is also, this is a great outcome. We had 0 identified pressure ulcers for this last quarter, far less than expected for a magnet hospital even. And also, this is great for a reflection of the type of beds that we're using, nutrition we're offering our patients, making sure that they're repositioned appropriately. And this is a reflection of 65 patients that were randomly observed, and none of them had stage 2 ulcers. So great outcome. Moving into our readmission rates, this continues to be one of the areas that quality is focusing on. It's a hospital initiative. We struggle in certain areas, and in other areas we are seeing improvements. One of the areas where we've seen improvement is for patients who had AMIs, otherwise known as heart attacks. We did only have 1 patient readmitted this quarter, putting us at less than the national benchmark from CMS. Pneumonia continues to be a challenge for us. We did have 18 patients admitted. This puts us slightly over the benchmark. These patients were complex. They were all over the age of 79 or above. We're continuing to look at ways of improving transitional care planning, medication management, follow-up phone calls, working with the attendings, et cetera, to manage this patient population, as well as documentation improvement in the medical record. Heart failure is the biggest challenge we had this last quarter. It went up to 24 patients being readmitted, putting us at 28%, whereas CMS benchmark is at about 22%. And so this is a case where we've drilled down on all of these. The readmissions team is looking at these very carefully. It is very similar plan to pneumonia prevention, really coordinating that care early on in the patient's admission, making sure they have a solid plan and that they're not likely to be readmitted following the same rules of transitional care that I mentioned with pneumonia. So we'll continue to focus on this high-risk complex group. COPD actually decreased, which is great. We only had 3 readmissions, putting us at 12.5%. Benchmark is closer to 19.7. Our RT team is working very closely with this patient population, and I'm happy to report that we have seen some improvements as a result of that. Coronary artery bypass graft, otherwise known as patients who have CABG. We did have 3 readmissions. This has put us at 12%. The goal is 12.6, so we are actually under for this group for what was expected. And then lastly, we did actually have a readmission in a patient who had a bilateral knee replacement. And this is atypical. As you can see, it's not very often at all that we have readmissions. This is an unfortunate circumstance where a patient had a bilateral knee replacement and 18 days after being discharged fell and had a fracture and had to come back. Absolutely, this patient needed to be admitted. This is not something preventable, and it's an unfortunate case.
Yeah.
And that concludes my report tonight for quality. Thank you.
Thank you. Thank you, Marie. End on that scary one.
I know. Yeah, it's about that. Oh, wow. Unusual.
Yeah.
Especially after going through a bilateral knee replacement.
Yes.
Which, you know,
oh. I hope they're doing well. Oh, yeah. My goodness. So thank you very much. I know the team is working hard. Everything that we can control seems like they're on top of it, and numbers are good. It's once they leave us that you have no idea what's going on at home. But thank you for all the work that your team is doing to keep our patients safe. Thank you so much. Any questions for Mary before we let her go? Wonderful. Thank you again, Mary.
Thank you.
Okay, we will continue to move on. Chris Henry, our finance report.
Yeah, thanks, Director Yee. Tonight we will be looking at Washington Hospital's operational and financial results for March. and we'll move right into the inpatient statistics. Inpatient average daily census for the month was 4.5 lower than we expected in the budget at 164.5. But when we fold in our outpatient observation days, and these are patients that are in beds, but not counted in the average daily census as inpatients. But when we consider that, we come up with a combined average daily census that was 1.8 below budget at 174.7. Admissions for the month were 16.6% below budget at 801. However, our patient days were only 2.7% below budget at 5,100, and that indicates a longer length of stay for the patients. And in fact, on average, our patients stayed a half day longer than we had anticipated in the budget at 6.01 days. Outpatient observation equivalent days for the month were 317. We had budgeted for 231 in the month, so we had a lot of observation. Moving into utilization, the case mix index for the month came in below budget, but still high from what we've traditionally seen at 1.621. Deliveries were 21 below budget at 110, but our both surgical and Cath Lab volume was higher. Surgical cases were 89 higher than budget at 442, and I believe that's an all-time record for the number of cases in a month. Cath Lab cases were 20 higher than budget at 233. Our outpatient visits for the month were 931 higher than the budget at 8,606, and that variance primarily driven by X-ray, cardiac rehabilitation, and outpatient wound care visits. Emergency room continued busy, but closer to budget this month at 4,202 visits. We expected 4,142 for the month. Moving into utilization again, surgical cases, as I mentioned, highest ever at 442, largely driven by our joint replacement cases, which at 205 was also the highest number of joint replacement cases that we've done. Neurosurgical cases, cardiac cases, and other surgical cases also were above budget. In the Cath Lab, again, 233 Cath Lab cases for the month. Cardiac cases for the month were 16 below budget at 91, but those were offset by higher volume in the peripheral vascular, non-vascular interventional radiology, and neuro interventional radiology areas. Looking at productivity, our productive FTEs for the month were 5.4 higher than budget at 1,419.5. Non-productive FTEs were 59.5 higher than budget at 181.8. And included in that number was an increase in FTEs that we incurred as a result of the mandate to provide 2 additional weeks of COVID sick pay to our employees. That mandate was issued in February and was retroactive back to the first of the year. So we had to do some retroactive adjustments and additional payments to our employees on a retroactive basis to adjust for that. So that's really what's driving up those non-productive FTEs. It also drove up our salaries and wages about a little over $500,000, as you'll see shortly. But we ended up the month with total FTEs 64.9 higher than budget at 1,601.3. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in very solid at 5.66. We had budgeted for 6.41, so we were very productive in the month of March. Moving into the financials, and as always, first we'll look at the Governmental Accounting Standards Board format. This is the format we're required to use for our audited financial statements. With all that activity, our total patient revenue was just under $10 million higher than budget at $209,053,000. Our deductions from revenue came in lower than budget at 77.17%. Really driven in the area of our provision for bad debt and charity for the month. Contractual allowances came in right about where we would expect them, with 5% higher total patient revenue. We see those contractuals also up about 5%. But our provision for bad debt and charity was down significantly. Our private pay in the payer mix was 1.1% versus 1.9% in the month. And as a result, our provision for bad debt and charity came in $1.153 million, lower than budget. We would have expected that actually to be higher than budget by about $300,000 based on the revenue. So that payer mix really helped us out in the month. So we ended up March with net operating revenue that was 7.8%, or a little under $3.5 million higher than budget at $48,097,000. Operating expenses for the month came in a little over $1.1 million higher than budget at $43,811,000. Had a lot of inputs to that. Salaries and wages for the month were $783,000 higher than budget. You know, that was really consistent with what went on with our FTEs and that retro of about $500,000 for the COVID sick pay. Benefits were below budget for the month, about $870,000, largely driven by lower health and welfare claims. Supplies were $553,000 higher than budget in the month. Prosthesis reagents were both higher in the month by a total of about $550,000. With the higher joint replacement cases, those prosthesis went well up, and we were doing a lot of COVID testing in the month, driving up the reagents. We also had higher expenses for personal protective equipment and our cardiovascular supplies that were offset by lower drug costs in the month. We did use less remdesivir in the month on our COVID patients, so that drove about a $234,000 positive variance for drugs. Pro fees for the month came in $673,000 higher than budget. About half of that was driven by higher hospitalist costs for the month. We also had higher expenses in consulting. We're working with, as you know, consultants on some clinical operations and revenue cycle improvement initiatives. And so the consulting fees for that drove those numbers. Purchase services for the month was about $380,000 higher than budget. We did have some unbudgeted architect fees in the month that drove a good part of that. And also the bed reservation program that we are utilizing in the skilled nursing facilities in the area to help move patients to a more appropriate level of care and get them out of the hospital, which is better for the patients, drove about $100,000 of that variance. Our insurance, utilities, and other area was below budget about $164,000, and we're seeing lower costs in our shared savings program that we have in partnership with some of our physicians. And depreciation for the month was $266,000 lower than expected in the budget in March. So we end up the budget or the month. I'll get the word right. We end March with an operating bottom line that's almost $2.4 million better than budget at $4,286,000. We did have a non-operating loss for the month of about $2.6 million, really driven by an unrealized loss in our investments of about $2.6 million. You know, that's a big number, and I just want to remind everybody what that number represents. As you all are aware, district law restricts us to investments in fixed income securities, bonds, and in an environment where interest rates are going up, bond prices go down. Bond prices have an inverse relationship with interest rate moves. So if interest rates go up, bond prices tend to come down. If interest rates go down, bond prices tend to go up. And so those ups and downs in value are what drive this unrealized loss or gain in investments. So for a number of years, we've seen pretty good gains on those investments as interest rates dropped. Now we're in a new environment where they're going up and those values are going down. They are, however, unrealized. This is a number that the Governmental Accounting Standards Board feels is important for us to reveal in our financial statements. This number is the change in that value from month to month in March, and on the year-to-date side, that's the change since June 30th of last year. They are unrealized by definition. They wouldn't be realized unless we sold some or all of our portfolio at a particular time. But right now, we're not doing that. Right now, we're holding on to those investments and letting them mature so we don't take these losses. So anyway, FASB does not recognize that number, as we'll talk about in just a minute, because they are, again, by definition, unrealized. And so Financial Accounting Standards Board and financial markets really don't pay any attention to that number when they look at us. So as a result of that, we have a total bottom line at the end of the month of $1,675,000 from a FASB perspective against a budget of just over $2 million. Now we'll take a look at how FASB might look at this. First thing we do for a FASB presentation, and again, this is the Financial Accounting Standards Board presentation. This is how the financial markets might adjust our financials when they look at us. So the first thing they do is they reclassify our revenue bond interest expense out of non-operating, where GASB wants us to have it, up into operating expenses. So we end up with operating expenses from a FASB perspective of almost $44.4 million and a total bottom line of $3.7 million on operations against a budget of $1,366,000. Non-operating, however, turns into income because they eliminate both the GO interest expense and the tax revenue that supports the debt service on those bonds. FASB doesn't recognize that, and that $2.6 million unrealized loss goes away because they don't recognize that. So we end up with a total bottom line from a FASB perspective of just a hair under $4 million against a budget of a little bit over $1.7 million. So you can see the impact of how the two different organizations look at that. Moving into our earnings before interest, taxes, depreciation, and amortization format. First thing we do is we look at our operating expenses before depreciation, which is a non-cash number, and we end up with EBITDA of $7.9 million for March. Then we go and we look at our non-operating results before interest expense, and as a result of that unrealized loss in our investment, that number turns into about an $879,000 loss. So combined, our Washington Hospital's operating and non-operating activities provided about $7 million to go towards our debt service, capital expenditures, and program development. So are there any questions on March?
I don't have any question. I just have a comment. The valuation in the securities portfolio is only meaningful, as you said, if we ever sold those securities, which we have no reason to do at the moment, given the amount of cash that the operations are producing. So in reality, it's good news, even though it from a GASB perspective, it looks like something that's not good. But the good news about it is that interest rates are going up, and consequently, in the long run, we will make more money from our securities portfolio as we roll over the maturities that come up. So that's good. In reality, that's a good thing. In the GASB accounting, it looks bad, but in reality, it's really a good thing.
Yeah, you know, and that portfolio is laddered, as Director Wallace mentioned, with staggered maturity dates. And as you recall, we did shorten the duration quite some time ago in anticipation of increasing rates. So as rates go up and those bonds mature and we roll them into new investments, we will be able to, the yield on those investments will climb with interest rate increases.
It's like anybody that has a CD. This rising rate market for savers and investors is going to be a beneficial thing. So for the last, I don't know how many forever years, savers and investors on fixed income have been getting very little return for the money that they've invested. Well, that now is changing, and so you know, it's hard to feel bad about that. I mean, for borrowers now, that's going to be a different, you know, sack of potatoes. Borrowers will pay more, but investors in fixed income and savers will get a better return than they have been getting for like forever. And so seems like.
Yes. Yeah.
Okay. And the good news is we have all of the debt obligations that we had. We acquired the debt obligations for the district during very low, next to nothing interest rate periods. So that's just that's really great.
Yeah.
Yeah.
Okay. Thank you for your optimistic perspective. I appreciate that. Thank you, Chris.
Okay.
Okay.
All right. Thank you. I will now present the preliminary results for April. As you will see, we were not as busy as March numbers, but starting with gross revenue. Gross revenue of $181.9 million for April was above budget by $4.3 million, or 2.4%, but was below April 2021 by $1.9 million, or 1%. Inpatient gross revenue of $103.1 million was below budget by $17.3 million, or 14.4%, and $6.8 million, or 6.1% below April of 2021. And again, this was due to fewer admissions that I will be showing you, and then also what we've continued to talk about is the shift in joint replacement cases from inpatient to outpatient. Our outpatient gross revenue of $78.8 million was above budget by $21.6 million, or 37.8%, and $4.9 million, or 6.5% above April of 2021. In terms of our COVID numbers, in April, we had 22 COVID-19 discharges, representing 3% of total discharges. And again, this was a decrease from the prior month at 50 COVID-19 discharges and was slightly lower than the April 2021 number of 26 COVID-19 discharges. So we have continued to see that number be low. Looking at our key census statistics, our average length of stay of 5.99 was above the budget of 5.29 by 0.7, or 13.2%, and above April of 2021 length of stay of 5.92 by 0.07, or 1.2%. Our outpatient observation days at 275 were above budget by 199, a budget of 199 by 76 days, or 38.2%, and 27 days, or 10.9% above April of 2021. Inpatient daily census of 140.5 was below budget of 148.9 by 8.4 days, but very close to the April 2021 average daily census of 140.3. Looking at our combined average daily census of 149.7, which was below the budget of 155.5 by 5.8 days, but 1.2 days above April of 2021. So the combined average daily census includes outpatient observation days. Looking at the average length of stay for our 22 COVID patients that were discharged in April, it was 11 days. I will say that in April, there were 13 discharges with lengths of stay greater than 30 days.
Wow.
And this ranged from 31 to 117 days. So if you exclude those 13 discharges, we were at an average length of stay of 5.08. So I will say we still have in-house, at the end of the month, we have 9 patients with lengths of stay that are over 30 days and counting. Unfortunately, they range from 38 up to 341 days, with 2 that are also over 200 days. So we still have a number of patients with a very high length of stay. So moving on to our admissions trend, admissions were below budget by 80 or 9.5%. Admissions for the month were 7 or 0.9% below April of 2021. In April, only 17 cases of the joint replacement cases were inpatient compared to a budgeted number of 58 cases, so a difference of 41. So you can see that shift. Moving on to patient days, our patient days of 4,216 were below budget by 252 or 5.6%. Patient days for the month were 8 or 0.2% above April of 2021. While admissions were down 9.5%, patients that were admitted stayed longer than anticipated, resulting in patient days that were down by only 5.6%. Then moving on to our surgical trend, our total surgeries in April of 373 were above budget by 41 or 12.3%. Surgeries were 16 or 4.1% below April of 2021. Inpatient surgeries at 127 were 43 or 25.3% below budget and 16 or 11.2% below April of 2021. Our outpatient surgeries were at 246, which were 84 or 51.9% above budget and consistent with April of 2021. As we've continued to talk about every month, we've said that the outpatient joint replacement cases were budgeted to begin to migrate to the Peninsula Surgery Center. We haven't seen that yet. As you know, we've been waiting for our Medicare accreditation, and I will say that this month they did come, and so we're in the process now of responding to the survey. There were no major issues found, and so we do have to put in place a few plans of correction, but we plan to start our operations hopefully in June. So that is the update on the Peninsula Surgery Center. So, and as you know, we waited quite a few months to have them come for our accreditation. So moving on to our surgical activity broken down, you can see our joint replacement surgical cases were above budget by 42 or 30.7% and were 19 above April of 2021. Our neurosurgical cases were below budget by 1 or 4.2%, but were 1 above April of 2021. Cardiac surgery cases were above budget by 1 or 20%, but were 7 below April of 2021. We did have one of our cardiac surgeons that did take some time off in April. All other surgical cases combined were below budget by 1 or 0.6 and 29 below of April of 2021. Moving on to our Cath Lab. Our Cath Lab cases for April were at 200, which were 4 or 2% above budget, but 24 or 10.7% below April of 2021. Our Cath Lab inpatient cases at 107 were in line with the budget, but 10 below April of 2021. And our outpatient cases at 93 were 4 or 4.5% above budget, but 14 below April of 2021. April of 2021 was a very busy month for us in that Cath Lab. Moving on to the breakdown of the Cath Lab activity, our cardiac cases were above budget by 4 or 4.2%, but 11 below 2021. Our non-vascular interventional radiology cases were above budget by 1 or 1.7%, and 5 above April of 2021. Peripheral vascular cases were above budget by 3 or 7.9%, but 10 below April of 2021. And neurointerventional radiology cases were below budget by 4 and 8 below of April 2021. And we've continued, as you know, have seen that the neuro IR number of cases continue to fluctuate quite a bit from month to month. Moving on to deliveries, our deliveries for April of 106 were below budget by 8 or 7%. And we're really spending some time sitting down with our OBs and talking to them about their volumes and talking to them about their estimations. And so looking at what we can do to continue to see if we can increase that, the volume of deliveries, because it has been down for a number of months. Moving on to our non-ER outpatient visits. Non-emergency outpatient visits of 7,414 were below budget by 226 or 3%, but were above April of 2021 by 17 or 0.2%. This was primarily driven by our lab visits at 2,569, which were below budget by 12.1% and 7.4% below the prior year. Our X-ray visits were at 1,620, which were below budget by 10.8% and 3% below the prior year. We have been having some equipment issues in terms of our outpatient imaging center, so we're looking at what we need to do in terms of potentially a replacement down the road. Offset of these two decreases in X-ray and lab visits, they were offset by our cardiac rehab visits that were above budget by 257 or 52.4% at 747. Our cardiac rehab has been coming back, but it is still about 6% below our pre-COVID-19 average of about 796 per month. Our emergency room visits of 4,186 were above budget by 389 at 10.2% and 13.3% above the prior year. So continue to see a busy emergency room. Looking at our gross revenue recap, surgeries were higher than budget by 41 or 12.3%, and there were more joint replacement cases with a higher revenue per case, driving our revenue above budget by 5.9 million or 18.6%. Our Cath Lab revenue was up $910,000 at 7.5%, and there were more cardiac cases than anticipated that drove up the average revenue per case there. Emergency visits were above budget by 389 or 10.2%, driving emergency room revenue up by 846,000 or 8.3%. Deliveries were below budget by 8 or 7%, resulting in a decrease in revenue of 167,000 or 5.6%. Ancillary services were below budget by 445,000 or 0.5%. This is primarily due to the lower inpatient activity that we saw. And then patient days were below budget by 252 or 5.6%, and we had fewer patients in ICU. As a result, our room and board revenue was below budget by 2.8 million or 7.9%. You can see. Looking at our preliminary payer mix for the month of April, our government-sponsored patient revenue made up 74.3% of total gross revenue. This is higher than the budget by 1.2% and higher than the prior year by 1.6%. Our HMO was 2.8% of gross revenue, which was above the budget of 2.6%, but was lower than the prior year percentage of 3.4% of gross revenue. Our PPO was 21.7% of gross revenue, which was below the budget of 22.3% and lower than the prior year percentage of 22.3% of gross revenue. And then lastly, our private pay was 1.2% of gross revenue, which was below the budget of 2% and lower than the prior year percentage of 1.6% of gross revenue. So we'll have to see how it plays out with our payer mix. Our preliminary productivity indicators, our productive FTEs were above budget by 9.5 or 7.7% at 1,318.1. Non-productive FTEs were above budget by 42.2 or 26.9% at 199.1. Our total FTEs of 1,517.2 were above budget by 51.7 or 3.5%. Looking at our productive FTEs per adjusted occupied bed, that was at 5.32, which was lower than budget by 5.96, by 10.7% or 0.64, and lower than the prior year of 5.45 by 2.4% or 0.13. Total FTEs per adjusted occupied bed also was favorable at 6.12, which was lower than the budget of 6.67 by 8.2% or 0.55, and lower than the prior year of 6.28 by 2.5% or 0.16. So overall, in terms of controlling our FTEs and our productivity, we did a good job this month. Looking at our other preliminary outpatient statistics, the Washington Township Medical Foundation clinics were below budget in April by 1,101 or 6.3% at 16,432, and were 2.7% visits below of April 2021. The largest driver is we did budget for an additional cardiologist to join us earlier, but we do have the individual that will be starting at the end of June. The other primary driver of the decrease in visits was in GI and gastroenterology, and those visits were down because the physician had taken some time off that month. Then moving on to our Development Corporation outpatient visits of 2,109, they were below budget by 9.4% for the month of April, and 8.6% below April of 2021 visits. Our Washington Outpatient Rehab Center was above budget by 12 or 0.9%. Washington Radiation Oncology Center treatments were below budget by 32.7% or 121 treatments. And I do just want to explain a little bit about the situation. As you know, we implemented Varian, a new linear accelerator. And what we've been finding is that our patients now are able to receive higher dosage treatments. And so so on the good side, it is requiring fewer visits for their course of treatment. So what we're seeing is the number of patients coming in is increasing, but the number of treatments per patient have decreased. And so I think that's something that we're going to look at going forward as to how we budget given this new technology and the new linear accelerator. So it's not that our number of patients are decreasing. So I want to just make sure that the board of directors is aware of that. Moving on to Washington Outpatient Surgery Center, volume is down by 6.9%, and this is primarily driven by a decrease in GI cases due to a physician taking time off. And Ohlone Student Health Center is down by 77 visits, and the health center continues to remain open. However, 75% of the students are continuing to take their classes virtually, so they really don't have as many students on campus at this point. But I know the staff there are busy doing other things in terms of education and working with the college on other health-related matters. So moving on to key financial statistics and charity, our days cash on hand for April ended at 163 days, an increase of 5 days from last month, primarily due to us receiving our QIP federal supplemental funding. It was $4.5 million, or equated to about 4 days, and also we had a strong patient collections in the month that also amounted to about 1 day. Looking at our days in accounts receivable, as of April 30th, we were at 61.3. So we've continued to make good progress in that area, and we saw a decrease of 3.3 days from the prior month. And again, we had a very strong collections in the month at about $44.4 million. Then lastly, our charity care was $165,000 that we did in charity care adjustments for the month of April compared to the prior month of over $211,000. So that is my report for this evening. Are there any questions about April?
Very good. All right, then thank you very much, Kimberly. You have announcements for us?
I do, and I'm going to start with the Employee of the Month, and that is Teresa Wallace. She is a patient account representative, and so she's Employee of the Month for May of 2022. Sometimes you choose a career, and sometimes it seems a career chooses you, says Teresa. Our May Employee of the Month, Teresa Wallace, always felt drawn to the healthcare industry. From the time she was in high school, Teresa had an aptitude for caring for others. As she developed her knowledge for bookkeeping and medical insurance, Teresa worked for medical offices and a medical insurance company. In 1988, her experience led to a Kelly Girl temporary assignment at Washington Hospital. After a short time, Teresa knew she had found her niche, and when a full-time role became available, she happily joined the team. That was on May 1st, 33 years ago. Teresa's experience working with HMO and PPO insurance accounts has made her a valuable asset to patient accounting and to the task force group that she works with. She has developed appeal letters used in response to insurance company denials, and those letters have become templates for future billing guidelines. The role of a patient account representative can be challenging, but Teresa maintains empathy for our patients by putting herself in their place. This, she feels, helps her to understand their perspective and helps her to practice our patient-first ethic. A Newark resident, Teresa and her husband, Steve, enjoy motorcycle trips on his Harley to the wine country or the ocean. Teresa is one of those special employees who may not work in a clinical care area, but who serve our patients on a daily basis, focused on the patient-first ethic. Congratulations to our May Employee of the Month, Teresa Wallace. And I will say, I know I saw her today at Hospital Week meal, and she was like, I enjoy every day coming to work. So it's wonderful. She really is. She's just, and after 33 years, so that's wonderful.
It's a great testimony.
It is, very much so. I just have a few more announcements that I'd like to go through, Director Yee. So starting with our past health promotions and outreach events, during the month of April, Washington hosted 12 students from Mission Valley Regional Occupational Program for a job shadowing program. The students were given the opportunity to spend 8 hours in a specific operational area, and they were hosted for job shadowing in our special care nursery, 4 West, 5 West, 6 West, and the Sandy Amos Outpatient Infusion Center, along with the clinical lab. So it's always wonderful to be able to introduce students to the healthcare industry and the different opportunities available. Looking at our vaccine clinic from April 13th, we provided over 214 second booster vaccinations at the Masonic Home on April 13th and 14th. And then as of Monday, May 2nd, a total of 87,940 COVID vaccine doses have been administered to community members at our vaccination clinic. And this represents both first and second doses as well as third booster doses. On November 3rd, as you know, we began vaccinating children ages 5 to 11 years old. And as of Monday, May 2nd, a total of 3,588 vaccinations have been administered to this age group. So I recommend, if you haven't gotten your next booster and you're eligible, that we do have our clinic. And so please feel free to give us a call and schedule a time to come in. Because we know the numbers are rising in certain areas, as Dr. Hyder said. So Moving on Tuesday, April 19th at 3:30 p.m., Dr. Rajiv Saigal, neurosurgeon, presented treatments and procedures for common spine conditions on Facebook Live and YouTube. We had 144 community members participated in the live event, and since then, 673 additional people accessed the presentation on one of our social media channels. We had the HERS Breast Cancer Foundation that recognized Dr. Bogdan Aftemia, hematologist-oncologist, with the foundation's Renewal Award at their 13th Annual People with Purpose Gala on Saturday, April 23rd. This award was in recognition of his professionalism and expertise in providing compassionate patient care. So I know we're very excited that he was recognized for this. Then Earth Day 2022 was celebrated on Saturday, April 23rd with the Let's Go Green community event that was co-sponsored with the City of Fremont and Washington Hospital. The celebration was hosted at the new downtown event center and plaza and included 64 exhibitors who helped raise environmental awareness for the community. It had featured many different areas, including free residential drop-off services that resulted in collection of 70 pounds of sharps, 120 pounds of unused medication, 600 pairs of glasses that were donated, 200 pounds of unused condiments and utensils, and almost 10,000 pounds of confidential paper that was shredded. There were many giveaways, including tomato plants and seedlings, and there was also dozens of kids and families that participated in the bike rodeo and had their bicycles tuned up throughout the day. More than 1,200 people attended the very successful event, so we're always excited to participate in it. Then moving on Wednesday, April 27th at 3:30 p.m., Desiree Naharibian, our certified diabetes educator, presented diabetes self-management, lesser known factors impacting blood glucose levels. We had 122 community members that participated in the live event, and since then, 409 additional people accessed the presentation on one of our social media channels. We also had on May 3rd at 3:30, Jessica Miller, our certified childbirth educator, presented Newborn Parent Boot Camp on Facebook Live and YouTube. We had 99 community members that participated, and then 368 additional people accessed the presentation. In terms of upcoming events, we have on May 12th at 6:30 p.m., Dr. Bhaskari Pila, our pediatrician with Washington Township Medical Foundation, will present kindergarten readiness on Facebook Live and YouTube. We also have on May 12th, Dr. Seema Sehgal, psychiatrist, and Wahi Khan, our licensed marriage and family therapist, will be on site at Ardenwood Elementary School for National Mental Health Awareness Month. And they'll be doing classroom presentations to students in kindergarten through 6th grade and follow up with some virtual presentations on May 26th also. So important to talk about mental health and well-being. May 18th, Christy Caracappa, our Health Insurance Information Service Coordinator, will present on advanced healthcare directives and PULSE, physician orders for life-sustaining treatment at the residence of Acacia Creek in Union City. And then on May 19th, from 6 to 7:30 p.m., we have Washington Hospital will host the Celebration of Life. And this event will feature stories of survival and hope for cancer survivors and their families. And the event is sponsored by Washington Hospital, HERS Breast Cancer Foundation, UCSF Washington Cancer Center, Invite, and the Tri-City Voice. So we look forward to that. Then lastly, we have on May 20th, our Washington will participate in the annual Bike to Work Day, hosted by Bike East Bay, and the Green Team will host an Energizer station at the Fremont BART station, and a group of employees will bike to work that day. So maybe even me part of it. I've even said, not the whole way, but part of the way. No, I'm going to do after the bridge. I do want to report that we had a very successful the foundation did 35th annual golf tournament that took place on Thursday, May 5th at the club at Castlewood. The tournament was a great success, and golfers were happy to be back at the course after 2 years. We are still, totaling out everything, but we think we've raised around $70,000 at the golf tournament. So it was very successful. So thank you for everyone that participated.
Mm-hmm.
So I also want to let you know that at the April quarterly meeting of the foundation, our trustees voted to disperse $277,508.09 to the hospital in support of COVID response needs, equipment for the emergency room, and special care nursery. So the foundation has contributed over $1 million to the hospital in fiscal year 2022. So thank you very much to the foundation. So that is my report for this evening.
Great way to end. Thank you so much. Yeah, thank you to the foundation. Exciting things happening.
Yep. Very
good. Well, if you look outside, the sun is still up.
Yes.
Surprise, surprise. Well, there being no further business and no need for a closed session,
right.
This meeting can be adjourned and we can get outside and maybe enjoy a little bit more of this day. But thank you all for your participation and have a wonderful evening. Thank you all. Happy Hospital Week.
Thank you. Thank you.
Bye-bye.
Good night,
Bye.
everybody.
Good night.